So I'm going to be talking to you about pelvic floor dysfunction. We're going to start off with a little bit of audience participation. I'm going to start with the easy questions, okay? How many women are in the room? Raise your hand. Everybody's hand should go up, right? Okay. How many of you have a pelvic floor? Everybody's hand should go up, right? And if the dudes were here, they all have pelvic floors too. So men have pelvic floor dysfunction. They also have pelvic floors, okay? Next question, everyone's going to be as honest as you can. How many people have ever leaked even one little drop of urine when you've jumped, coughed, sneezed, laughed, deadlifted? Look around, okay? You're not alone. And that's what I would expect, because statistics show us that 1 in 3 women will experience a pelvic floor dysfunction in their lifetime. 1 in 3, and we're all fit women in here. More than 50% of women aged 55 and older suffer one or more problems caused by pelvic floor disorders. So it's kind of an umbrella term, pelvic floor dysfunction. It's not only incontinence, there are other things that can go on too. But we see that the incidence increases with age. 30% of women with overactive bladder or urinary incontinence also suffer from lack of bowel control. That means you poop your pants when you don't mean to. And that's never a good thing, right? But there are things that we can do about all of this, and I think it's really important for us to talk about this stuff. So pelvic floor health is not new. The American Physical Therapy Association has a section on women's health, an entire section devoted to women. That's our kind of people, right? That started in 1977, and there have been some name changes and mission and vision changes to reflect that we're now treating men and things like that. So this is not a new topic for physical therapists. But has anyone heard more about pelvic floor dysfunction lately in the fitness industry? So why is that? CrossFit, okay? I don't know if you can see with the lights on, but this is what Cass was just talking about. Her pants are wet. So how many people saw, not just this past year, but the year before in the CrossFit Games, where they went around and interviewed women in the audience to ask how many women had pelvic floor dysfunction? So did anybody think, like, oh crap, when they saw this? Like, women's health physical therapists were aghast at this only because they made it sound like it was just something that's going to happen. And they even had a woman who was supposedly a gynecologist in the audience who said, oh yeah, it's totally normal. And we were all like, no, it's not. So something that you'll hear me say a lot is it's common, but it's not normal. It's not anything you're doing wrong. There's no blame in it, but it's just not normal, and there are things that we can do about it. The good thing about that exposure from CrossFit is that it brought this issue more toward the public eye, more toward giving it attention. And even Ryan Gosling feels bad. Hey girl, I don't think anyone noticed that you peed yourself during those double unders. Well, they did notice, right? Because there it is. And if they didn't notice, it's because you were probably wearing a pad. How many women in the room wear a pad when you work out so that you don't leak all over the place, right? A couple are being honest, right? So, and this is something that I tell the guys a lot when I talk to the guys about pelvic floor dysfunction, because they're like, oh, that doesn't happen in my gym. And I'm like, it's because all the women are wearing pads. And they're like, oh, really? But they don't think to ask, and they don't know, and the women tend to talk about it just amongst ourselves, and we don't always bring it up to our trainers. So anyone here that is training women, or your husband or your boyfriend or someone you know, please tell them to be aware that this is going on, okay? So what are some women's health issues? We're talking about incontinence. There's also pelvic or vaginal pain, pelvic organ prolapse, where the uterus or the bladder can start to descend onto the pelvic floor and even start to come through the opening. Prenatal and postpartum musculoskeletal pain, the general aches and pains, the back aches, the hip pain you have when you're pregnant or afterward. Osteoporosis, rehab following breast surgery, mastectomy. Lymphedema is something that also goes along with that. Sometimes after a mastectomy for breast cancer, women end up with a lot of swelling in their extremity, and physical therapists work with that. So what is urinary incontinence? Urinary incontinence is the leakage of urine at inappropriate times. And sweetheart, there is no appropriate time to leak urine unless you are sitting on the toilet, okay? Any other time is a bad time, okay? So there are 3 different types of incontinence. Stress urinary incontinence is probably the biggest one that we're talking about with a fit population. That's when small amounts of urine leak out when there's increased pressure on the bladder. So the cough, the sneeze, the jump, the heavy deadlift, things like that. Urge incontinence is when your bladder goes into spasm. So you're trying to get to the bathroom and you just can't get there in time and oh shoot, there it goes. But that's because of a spasm of the muscles, okay? And so small amounts or large amounts of urine may leak, it just depends. And then there's mixed incontinence, so you can have both. You can have stress incontinence, but also urge incontinence, okay? So we're not gonna really go over a lot of the pelvic floor anatomy, but this is the view, this is your gynecologist view, looking at you, okay? Except there's skin over it, normally. But what I want you to notice is that you can think of this as like a sling, basically. So the pelvic floor is everything between your pubic bone and your tailbone, your coccyx. And so the muscles run this way and they run up and down, and so there's just all this support built in there, okay? So stress urinary incontinence, leaking urine during coughing, sneezing, running, jumping, or lifting. As I said, it is common. We can see that just in this room, but not normal. This study, Piston and others in 2002, they looked at 291 elite female athletes. Out of those 291, 151 reported that they had stress urinary incontinence. 5 discussed it with their medical provider. And it says 6 got treatment. I don't know, 1 got better by accident, maybe. You got treatment by accident while she was there for something else. But that should be disturbing to all of us. Out of 151 women, 6 got treatment. Can you imagine if we were talking about knee pain? Oh, here's 151 elite female athletes with knee pain, but only 5 of them got treatment. That would never happen. So part of that is the stigma of women being afraid to bring this up. I can't tell you how many women I treat in my physical therapy practice who have been going to chiropractors or other physical therapists or their OBGYN for years, well, not the OBGYN, other healthcare providers, but no one's ever asked them if they have incontinence. And so maybe they've been treating their back pain or their hip pain or their knee pain, but no one has ever tied it together that they have incontinence. So leaking is a sign of the system breakdown. Everything between here and here, front and back and all around, needs to function as a system. Leaking or incontinence is just one way to identify a pelvic floor dysfunction because it's a very outward sign of the imbalance that's going on in the deep core stability system. This should be a closed pressure system, so you can think of it kind of like a canister. There's a top, there's a bottom, there's a front, there's a back. It's all one closed system. And the deep core provides stability for your hips, your low back, your knee, everything. It's your foundation. So as I said, some women may have hip or low back pain, chronic hamstring strains, adductor, groin strains. This is how most women get to me. I don't advertise that I'm a pelvic floor or a women's health physical therapist. And I was telling someone this morning, I kind of got into this by accident. I never thought this is what I was going to be doing. I'm an orthopedic physical therapist. But when you see hundreds of women who are coming in with the same story, you have to start paying attention and you have to be ready to treat them. And so that's how I kind of got into this, and now it's really become a passion of mine. So what are we talking about when we talk about the deep central core? There's all kinds of stuff out there, core strengthening and core, everything's core. What is our deep central core? We're going to think about that canister. So the top of the canister is our respiratory diaphragm. It's a muscle. We breathe with our muscle, the diaphragm. The bottom of the canister is our pelvic floor, that whole sling of muscles at the bottom there. The front is the transversus abdominis, which is our deepest core muscle. It functions kind of like a corset. And then the back of it is the multifidus, which are muscles that run 1 to 2 segments, 1 to 2 vertebrae segments up and down the spine, okay? So I like to, this is a word that I picked up from a friend of mine, Julie Wiebe. I know some of the other women here that I've talked to this weekend have looked at some of Julie's things. She's a friend of mine and a mentor. She came up with this idea of this system functioning like a piston, okay? So the deep core, the pelvic floor, the diaphragm, the transversus abdominis, and the multifidus is not static, okay? It's a dynamic system. It's in constant motion. Why? Because we breathe all day long, right? So when people tell me, oh, I went to physical therapy and I did Kegels and it didn't work. Well, we can't just train one part of the system and expect that it's going to fix everything, right? So the pelvic floor has to function as part of that team, and we're going to talk a little bit more about the piston in just a minute. The pelvic floor also, when we look at it with EMG studies, it turns on first before any other muscle. So before you go to jump to the side to kick or something like that, or you're serving in tennis or whatever you're doing, Zumba class, the pelvic floor and the transversus abdominis should be turning on first, automatically. That's what gives us our support and our control. And for our piston to function best, Molly kind of talked about this before, we need to be in alignment. So our ribs should be over our pelvis. How many of us don't function and don't live there? We're either here or here, you know, porn star posture, right? Everybody's in the gym with their hyperextension. So we don't want that. We want the ribs right over the pelvis. And we want our contraction to be graded to the task at hand, which is, again, why practicing a maximal contraction with a Kegel isn't always the answer. So if you're going to bend down to pick something up off the floor, you have a different motor strategy if that's a paper clip versus if that's a 40-pound bag of dog food, right? The pelvic floor is the same way. We don't need to do this maximal contraction to pick something like a paper clip up off the floor. So as part of the treatment and the training, we need to train it to contract in a graded method so that it's graded to the task at hand. So the piston, another way to think about this is kind of like an umbrella, and I think Molly might have even used that term. The ribs need to expand in all directions. So you think about putting up an umbrella, it's expanding together. So it's not just the chest going up and down, it's not just the ribs going this way, it has to go in a 360-degree fashion. As we breathe in, now stay with me because this is confusing for some people. As we breathe in, our diaphragm actually goes down. And the best way I can explain that is just think of it like sucking air into the lungs, okay? As the diaphragm descends and goes down, we need to have a soft, relaxed belly and a relaxed pelvic floor. Because, and I'm going to kind of exaggerate this so it's more obvious, as the diaphragm comes down, those abdominal and pelvic organs also need to come down a little bit, okay? So there's a natural descent when we have a relaxed belly and a relaxed pelvic floor. As we exhale, the diaphragm knows what to do. It's the one part of the system that just knows it's supposed to come back up. And then there should be more of like an elastic recoil of the pelvic floor and the transversus abdominis. So it's really cool when you look at cadavers. The fibers of the diaphragm run this way. A cadaver. Did I just say cadaver? That's the world I live in. I hope that doesn't gross anybody out. Dead people, which is part of our education as PTs. So the diaphragm fibers run this way, and the transversus abdominis runs this way. So as the diaphragm stretches down, we get this nice stretch of the transversus abdominis, if we're letting it happen. But for those of us who walk around with a really tight pelvic floor or the tight belly, and we're the upper chest breathers who always have chronic neck tension and pain, you know who you are, that whole system isn't allowed to function the way that it should, okay? That's when we start to run into trouble. So contributing factors for pelvic floor dysfunction. Everyone always wants to say it's because of weak pelvic floor muscles, right? Well, it can be. It can be that the muscles are weak. That's one reason. They could be stretched from pregnancy, from the weight of the baby on the pelvic floor. Could have been stretched from a vaginal delivery, especially with things like forceps or things like that. But they can also be weak because of postural habits. So women come in and they tell me things like this all the time. I have a flat butt. I want to have a better butt. And they call it like the long mommy butt. You know what I'm talking about, right? And the mom jeans and the butt's just like hanging down. They're like, I want to do something about this. But it's not just an aesthetic thing, okay? You can see it with this woman's posture, her ribs are not over her pelvis. That's going to affect the relationship between the diaphragm and the pelvic floor. So it's not only weakness. Sometimes hypertonicity or increased tension can be part of the problem. And this is when the pelvic floor muscles are overactive. They're always firing. They don't know how to relax. When a muscle can't relax, it also can't contract the best that it should. So I always give the example, we wouldn't walk around with our biceps like this and be like, I'm gonna pick up this table, you know, and like, we wouldn't do that. We need to let the muscle relax and then get a contraction. Take it through the full range of motion to get the best contraction possible. If you're someone who's worried about leaking urine all the time and you're constantly clenching, it's very hard for your pelvic floor to relax, okay? That's gonna affect the ability for it to contract. So the muscles can be overactive, but still weak. Does that make sense? Yeah. And again, we always want a graded contraction. We don't want to walk around tight all the time. Now, this is more appropriate to women who only leak when they're lifting very heavy, okay? You can have hypertonic, so always active pelvic floor muscles, but they're strong. You don't leak when you cough or you sneeze and things like that. Everything else is fine. But when you lift heavy, you might leak, okay? So you have a strong pelvic floor, but stronger abdominals, back muscles, diaphragm, or glottis muscle. Those are the muscles around your voice box. So the tennis players who, you know, they grunt, that pressure, again, it's a closed pressure system. That pressure has to go out somewhere, okay? Women who leak when they're lifting a heavy load, if they are holding their breath and they have a rigid thorax, right, bearing down, Valsalva maneuver type of a thing, they can't contain that pressure. It has to go out somewhere. It's going to go through the weakest link. That's either grunting or yelling. It's coming out this way. Leaking urine, abdominal hernias, okay, where you get tears in the muscle, or a herniated spinal disc in the back. Again, the pressure has to go out of the system somewhere. Another contributing factor is damaged pelvic floor muscles. So we talked about this a little bit. Episiotomy, where there's a cut made to help deliver the baby. Forceps delivery. Women who have been treated for cervical uterine cancer with radiation that can affect the quality of the muscle and the ability to contract because scar tissue affects muscle contraction. Another reason we could have trouble, maybe it's none of these things. We have a strong pelvic floor. We're not having pressure escaping from the wrong places, but we have a mistimed neuromuscular strategy. So again, it goes back to the fact that everything has to work as part of the team, as part of the system. And if you've ever rowed crew, and you know that everybody has to row at the same time, and if someone doesn't, the whole system gets off. And that's what happens with the pelvic floor. If you're not able to time that strategy so that you get the descent on the inhale and the rising on the exhale, you can end up with issues. So, can anyone tell me what they think this woman has probably always been told to do? Suck her belly button toward her spine, right? How many times do we tell our clients that, or how many times have we been told that? This is a patient of a friend of mine who does women's health, and you can see she's obviously strong, she's lean. She came to him and said, I've got this mommy belly thing that I want to get rid of, and I need to lose weight. What should I do? And he took a look at her, and this is how she stands. And it's almost like she's cutting herself right in half in the middle, okay? She's gripping because she thinks she's doing the right thing, pulling her belly button toward the spine. But you can see if she's gripping there, that whole system can't function properly. The diaphragm can't descend, right? And she can't engage her transversus abdominis, which is why she's got the belly sticking out there. It's not fat, it's just that she can't get those muscles to do what they're supposed to do. So what do we do? If you come to a women's health, pelvic health, women's physical therapist, we train the system. We train it all together, okay? teach you to relax your pelvic floor on the inhale and lift it on the exhale. Again, as a system, not just Kegels, so doing 10 Kegels at a stoplight, the reason it doesn't work is because you're not integrating it with your breathing and with your functional activities, okay? This needs to be trained in multiple positions, and when we do the hands-on stuff, we'll talk about this, we'll go through it. But we need to train in multiple positions so that we can really feel it. And we need to start, something funny. We need to do in multiple positions, and we need to do it throughout the day with our lifting and all the other things that we're doing. So this is just practicing breathing. I have women practice breathing in different positions, supine on your back, side lying. We start to add in movements with this. So this is another term from my friend Julie, blow before you go. So basically, the exhale is what starts when you're going to do any movement. So you think about your squat, you're inhaling on the way down, you start to exhale and you come back up. So it's just an easy cue to remember, blow before you go, before you start the movement. That actually activates your transversus abdominis, and we'll do that with some of the exercises. And then we add in things in other positions like clamshells, and not just the easy clamshell where you're like, whatever, I'm going to do 100 of these, but really focused and working on it with the breath and things like that. Squatting, so again, we just kind of talked about that. The band is kind of representing a relaxed pelvic floor as you're descending, and then a tighter pelvic floor as you're lifting back up. So if any of this resonates with you and you have issues, or you have friends who have issues and want some help, the American Physical Therapy Association has a public-facing website called Move Forward. That's moveforwardpt.com. There's a tab for Find a PT. I will say that only American Physical Therapy Association members are listed on that site, so that's not to say that there's not somebody really good near you that maybe just isn't a member and isn't on there. If you want to reach out to me, I'm prana-pt.com. That's my website. I have Julie Weeb's website on there. She has a really great program. If you're struggling with this issue and you can't find someone who's near you to help you treat it, she has a DVD, or you can also just download it, that takes you through what you would do with a therapist as a home exercise program. And they've done a study on it and things like that and had good results from it. If you're on Twitter, I'm at PranaPT on Twitter, and we tend to use the hashtag pelvic mafia. So if you use that, it's kind of like throwing the bat signal up in the sky. So if you have a question and you use that, one of us will usually get back to you. If you're looking for someone in your area and you haven't been able to find them, then we can help you with that. Questions? Yes.
I have a client, she's only 34 years old with a prolapsed uterus.
Right.
Will these types of exercises help her? I mean, the same thing? I mean, because
Yeah.
she wants to have another child, so
Right.
they want to go in and do a
A surgery.
Really uncomfortable. She can't run.
Right.
I mean, it's really affecting her quality of life.
So she's asking about pelvic organ prolapse, where the uterus or the bladder have started to already descend and put pressure. Yes, some of these things can help her, and it's, again, every individual is different, so it's a matter of how far along she is and whether her body's responding and things like that. For some women, they can use something called a pessary, which is a device that can be inserted to help lift the pelvic floor a little bit. She has one of those already.
Something like it's too big, or I don't
Yeah.
know a lot about it, so I was hoping to learn more today.
Yeah. Talk to me afterward, and I'll find out where you are, and maybe we can find someone to refer her to. I mean, as far as I'm concerned, it is always better to try conservative measures first. So I would always recommend find a physical therapist who you can work with, or through your OBGYN before you have surgery, because sometimes surgeons, well, they're surgeons. They have a knife and they want to cut, right? And they will tell you that that's the only option. But if you haven't exhausted all of your other options, you don't really know that's true for you. Yeah. Jen?
Is frequent urination a problem and related, even if you don't have leakage?
It can be. So she's asking about frequent urination. You know, the women who are like, I gotta pee, and like every half hour running to the bathroom. You should not have to go to the bathroom more than every 2 to 3 hours. I don't care how much you're drinking. You shouldn't have to pee more than every 2 to 3 hours, okay? Now that's what we will tell you if you come to a physical therapist. I know lots of women pee more often than that, but what you're doing is training your bladder to need to empty every 30 minutes, every 45 minutes. And so that's a strategy that a lot of women use because they know they're gonna leak if they go longer, right? So, and it's true in gyms too, you know, they know they're gonna do double unders, or they know that box jumps are coming and everybody's like, time to hit the bathroom, and everybody runs out and they all come back in. Well, you know, ideally you shouldn't need to do that. So yes, there are things that can be done. Amanda.
A little bit about the operation that can happen, because I have 2 clients that have had these issues, and this was like something that nobody knew about. Honestly, till the badge of honor from CrossFit came out, it was almost like never spoken about.
Right.
So I have 2 clients who are in their late 40s who've had the operation, and their life quality of life now is completely different.
Better?
No.
Worse.
It's better because they don't pee, but they can't even lift their kids up anymore.
Right. So she's asking about if women have the surgery, the corrective surgery, it solves the issue that they're not peeing when they don't want to, but now they're weak and they can't lift weights and they can't pick their kids up, and you know, quality of life should have gone up, but it didn't.
Am I right in that they've got limitations now because of the surgery? They can't lift more than 20 pounds because it may rupture?
You know, I don't think that's true. I think that's the fear if women are bearing down, you know, because a lot of women, when they go to lift heavy, you know, and we push down. And women may think that they're lifting through the pelvic floor, but I can tell you just from working with women that a lot of times they're not. So I think even after the surgery, and the docs a lot of times won't send you for physical therapy. And you guys, you need to be your own best advocates, and if you're training other women, you need to tell them these things and advocate for them. We need to go and say to our doctor, I want to go to get this taken care of, you need to give me a referral. And you can access physical therapy in all 50 states without a referral from a physician, and that's really important for people to know. In some states, you might only be able to have an evaluation. You may not be able to have treatment, just because the State Practice Act is different in every state. But you can go see a physical therapist.
I think like where a few of us in Canada here, or in Ontario now, the doctors will refer you to a PT because it's cheaper for the health system now than
Right.
surgery. And in France and in the UK,
Right.
it's the first point. They won't even talk to you about surgery until you've had an
We're so far behind in the US with taking care of women after having babies, really far behind. Say?
Canada as well.
Yeah. I mean, definitely, you know, in France, I think they get automatically, after you have a baby, you get 6 visits with a women's health physical therapist. Can you imagine how things would change? Because I'm seeing the women way down the line, maybe their kids are 3 or 4, and they've had this back pain, and of course I pee and I wear a pad, and you know, I never knew it was an issue. Why are we seeing that 4 or 5 years later, 20 years later? Why are we not catching this? Because our health system doesn't do a great job at preventive medicine. But again, you can always advocate for yourself and tell everybody you know that they can also do that and seek it out. Joy?
And this is super important also if you want to do strength training. Because I know like a lot of the cues I learned or when I learned, you know, they come kind of from the men's world. Brace, arch, you know, all that stuff. But when you translate it over to women who have had babies or have had issues there for a long time, sometimes we end up kind of shooting ourselves in the foot.
Yeah.
You know, doing that stuff we think we're supposed to do while we're trying to learn how to lift and get strong, stuff like that. So
Yeah, I mean, you can't lift heavy, like Molly was saying too about the foundation. You have to have your foundation, and if you don't, you're just throwing strength on top of dysfunction. I think that's a Gray Cook quote. But you know, you can't just build all this strength doing all this stuff if you don't have anything else going on down here to support you. Okay, you're gonna get hurt. That's not good. How are we on time? Are we good? Hands on? Okay.
I don't know how we're gonna do hands-on with our pelvic floor.
Well, you know, Amanda last night was like, so did you bring gloves? Like, is this gonna get weird? Like no, sweetheart. Right, no. So we're not really doing hands-on in that sense, because that could get tricky. The alignment is the ribs over the pelvis. So you guys can group up and look at each other, because you might be like, yeah, hey, my ribs are over my pelvis, and it's like, no, that's not going on. So look at each other so that you can give each other feedback. What I want you to think about while you're doing that, so just one more second. What I want you to think about while you're doing that, this is another great Julie Wiebe trick. Think of your ribs as a bell. So if you're thinking about your ribs being over your pelvis, your bell should be quiet. So we want the breast pointing straight ahead, ribs over the pelvis, okay? I did Pilates teacher training, and so one of the ways they explained it was like if you had a string through your spine and you had it hanging, like had a hanger, everything else would kind of drape around it. So it's that idea, okay? Sometimes I have people put like a Beanie Baby on their head and walk around, because, you know, if you think you're straight and you're not and the Beanie Baby's falling off, that gives you a good cue of where your center is and where your core is, okay? So I want you to think about where the weight is on your feet, okay? Do you feel most of the weight in your toes, or is it in your heels? Where do you feel the weight? It should be going through the center of the foot, okay? So think about that, all right? And then what is your butt doing? Is your butt here? Is your butt here? You don't want it tucked. I know a lot of times in exercise, like when we're locking something out, you know, it's like get that trash compactor position and really just, you know, root down. Okay, but we don't need to walk around like that all the time, right? That's an exercise. So you want your butt to be untucked, which I'm gonna say is like right about here. Okay, so you don't want this and you don't want that, but you want your butt untucked. So the whole thing looks like the quiet bell up here with the weight going through the center of your foot, and your butt is untucked. Does that make sense? Mm-hmm. Okay. So then the next thing we can do, you can bring your feet about hip width apart. And if you're not feeling all of this, sometimes what I have people do is get into like a ski jump position. So you're gonna bend your knees and shift forward just a little bit. And I want you to just do some breathing there in that position. I want you to think about relaxing your pelvic floor on the inhale, relaxing your belly, and then lifting through the pelvic floor and lifting, getting the TA to contract a little bit. Just do a couple of breaths like that. So think back to what I was talking about with the piston, that idea of things going up and down, okay? And if you're feeling it better, you know, in the ski jump, see if you come back up to the neutral position, if you can still feel it. And again, this is like something I'd be having patients work on this like over multiple days. We're doing like the 15-minute drive-by, you know, kind of a thing here, okay? But that's the idea, is once you can feel that piston in the ski jump position, you bring it back to neutral, okay? But it helps. So everybody, let's try this. Tuck your butt and get your weight way back on your heels. And I want you to try to lift through your pelvic floor. So if you've never done that before, that's kind of like the Kegel, and that's like the elevator coming in, everything's coming in and up. So you should maybe feel that you are contracting more around the posterior part of your pelvic floor, around your rectum. That's great if you have bowel incontinence. Not so great if you have urinary incontinence, right? So you don't want to be in that position. So now get the weight over the toes to go back to the ski jump and see if you can feel it. So do your relaxation on your inhale, and on your exhale, you're going to lift through your pelvic floor. So you feel it more toward the front part. Yes. Okay. So again, this is stuff you guys who are trainers and coaches, you can do this stuff as part of your warm-up with your clients. Okay, sorry, I have my back to you guys.
No, you're fine.
Hey. But yeah, that can be part of your warm-up when you're doing your breathing. And those simple little things like feel what you feel here, feel what you feel here, let's work with it there, and then we can get you back kind of to neutral, okay? And while you're doing that, you're still getting like that umbrella breath, that expansion of the ribs in all the directions, all right? So does anyone have questions on that?
Not that specifically, but do you know of any like certifications for trainers that can give us kind of like credentials to do this with clients, or like?
Yeah.
I mean, I think these are great tips, but I feel like it might be not in our like
The scope, right? I believe that there's a big education company called Herman & Wallace, and I believe that they just started a non-healthcare provider class certification, so you can find them online Herman and Wallace.
To answer that too, these are like good breathing concepts, even if you don't feel comfortable saying this will fix this or this is because of that. You know what I mean? Like, if you just do breathing and warm-ups, you can get across these concepts without kind of overstepping your expertise. if that makes
Right.
sense. You know what I mean?
Like
Right.
you're not diagnosing, you're just saying
Yeah.
these can
Correct. And you know, Molly was talking about it with the rock backs and things like, so some of these are similar to PRI principles, if any of you have used that with clients. And I haven't studied all the PRI stuff, so I don't know how much they go into the pelvic floor. It seems like maybe that's left out of the breathing. And what we don't want to do is, with encouraging that forceful exhale, we don't want women overusing their obliques and the rectus abdominis, because most women are overly using those anyway in the effort to get the six-pack and everything, and the TA is not really kicking in, okay? I will say that most of the women I work with have more trouble with the relaxation. They are more hypertonic, okay? And they're just, you know, and you can see it sometimes just looking at posture, and if someone is a butt gripper, you know what I mean? Like they're like, this, okay? So they're gripping, maybe they're gripping the abs, maybe they're gripping the butt, but those are your people who are gonna have trouble. And you know, when you put your hands on people, you can kind of get a sense of that, like, whoa, man, they've got like tension through the whole system here. Like, so again, starting with your breathing, not even mentioning pelvic floor or any of this stuff, which can be kind of scary and weird and freak people out. Just talk about breathing, okay?
If a person has a difficulty even doing like the pelvic floor contraction once you get to that point, is it beneficial for them to just really focus on their transverse abdominis, or is that counteractive?
So ideally, you want it all working together, right? For the people who have, for the women that I've worked with who have trouble with that, sometimes what I do, I don't do internal pelvic floor work, so I do everything externally. But I have someone that I refer to, which some women need, and they really need to, you know how the gynecologist does the internal exam with the two fingers. They need that, and then they need to feel what it feels like to be relaxed, what it feels like to contract around the fingers. So, you know, sometimes people just need 1 or 2 sessions with someone who can do that. I tell my patients, you know, you can do this at home. I mean, you really can, and people are like, I don't want to touch down there. But I mean, come on, we put tampons in, right? Like, we have to stop being so afraid of all this. It's just another set of muscles. So you can do your own internal exam and see if you can relax and if you can contract around your finger. So for some people, maybe that's enough. And I think it goes back to talking about scope of practice. If it's out of your scope of practice, just know enough to refer that there are other people out there who can help with this stuff. What's that?
Don't stick your fingers in anyone.
No, don't. There you go. I mean, we can all go home now. Just don't stick your fingers in anyone, and we're all good. That was all you need to know from this conference. Okay, so what we're gonna do is we're gonna lay down on our backs and we're gonna like try some of this stuff, okay? Okay, so everybody just bend both knees up and rest your feet on the floor. That just gets you in a more comfortable position. Sorry? No stirrups. We don't have any stirrups around here, no. Okay, so when you're lying there on your back, you want to feel like you have a quiet bell, okay? So even when you're laying down, if your ribs are pointing way up to the ceiling, your bell is rung up, right? If you feel like, God, my low back is all squished into the floor, your bell's probably rung down. So just kind of play around with that a little bit. I want you to take your hands, you're gonna make a little triangle. So you're gonna put your hands on your hip bones, and then touch your thumbs together, and then your fingers, your index fingers are gonna go right over your pubic bone. So you're making a little triangle, okay? And your triangle should be flat. So if your triangle is tilted down, you're tilted one way. If it's pointing up, you're tilted the other way. So if you can't get the triangle thing, don't worry, because it's late in the day, and you know, just put your hands there and you'll feel what's going on, okay? So ideally, you have a quiet bell and you've got nice flat pelvic triangle here. Now I want you to practice the breathing, okay? So on your inhale, you're gonna relax your pelvic floor, and don't even do a contraction of the pelvic floor on the exhale. Just feel what happens naturally if you can relax. So everybody do about 5 breaths with that. So is anyone having a lot of trouble feeling that? No? Everybody's pretty good? Okay. So we're going to move on, and again, I'm moving way faster than I would with a patient, but we're going to move on to the exhale to try to get the transversus abdominis to kick in. So just lay there and keep doing your breathing. You can just listen. Everything else is going to stay the same. On your inhale, your belly is relaxed, your pelvic floor is relaxed. On your exhale, I want you to breathe out like you're fogging up a mirror. So if you were going to go, okay? It's not a hard, forceful contraction. I don't want you to feel your obliques and your rectus and everything else kicking in. You've got your hands right over your lower belly. You can spread your fingers out if you need more feedback. You should feel the transversus abdominis between the hip bones starting to kick in with that. So this is, again, something you can do with your clients as part of your warm-up or your cool-down. And everybody can talk about breathing. There's no scope of practice on breathing. Okay. So let's add on to that. As you do your exhale now, what I want you to do is just lift a little bit through your pelvic floor. Okay, so everything else is the same. Relaxed belly, relaxed pelvic floor on the inhale. On the exhale, you're going to fog the mirror with your breath and lift a little bit through your pelvic floor. So if it helps, some of the cues that I use with patients, if you think about a jellyfish, how a jellyfish opens and then it contracts to move, you can think about that imagery for your pelvic floor lifting. You can think about if you were going to pick up a coffee bean or something with your pelvic floor. That's a really weird one, but it works. Thinking about relaxing around it and then lifting the bean up into the body. Another cue is to think about on the inhale that your tailbone is kind of relaxing into the floor and the vertical space between your tailbone and your belly is increasing. And then on your exhale, it's getting a little bit closer together.
You suggest they do this on their own? Like, you know, if you give
How often? So the question was, how often should clients do this on their own? I have them start with maybe 5 minutes in the morning and 5 minutes in the evening, but they can't do it while the kids are all running around and the TV is on and somebody's like, when's dinner? You know, you need to really have some quiet time to do this. I don't, do you do about the same couple minutes? From here, it's a matter of trying to train that breath with movement. So I typically have people start with maybe a heel slide. So if your shoes are kicked off, you're going to start with your legs out. So I don't know if there's enough room for everybody to even try this, but you're going to do the same breathing. Relax on your inhale. On your exhale, you're going to fog your mirror. You're going to lift through your pelvic floor. You're going to start to slide one heel towards your butt. And if you go all the way there, I know that you're faking it because nobody can do that right away with the breathing. So if all it takes is for you to just start to do that movement and you can still feel the transversus abdominis kicking in, then that's good. Okay. So you don't want to feel a whole lot of action in your hip flexors. You can put your hands over the front of your hips. If you're just really lifting your knee towards your chest, you're doing all hip flexor and your TA is probably not doing a whole lot to stabilize you. So it sounds easy, but it's kind of hard in practice to make it happen. From there, I would progress to, once they're really getting that, something like a clamshell. So if you guys would make this the last thing, if you want to try this real quick, turn to your side. So your head is in line with your butt and your feet, and your knees are bent. And you can rest your head down. There's, you know, nothing to see. Nothing to see here, folks. Yeah, great for your butt. So again, on your inhale, you're relaxed. As you exhale and you're lifting through the pelvic floor, you're fogging the mirror, you're starting to lift that top knee just a little bit, and then inhale back down. So you keep your feet together and your knees are opening like you're opening up a book. Okay? And you don't have to go all the way up, you're just thinking about the stability. So for some women, it helps to lay against a wall when you're doing this so that you're not rolling back and you're staying in line. And then, you can practice this later, but one side might be different than the other. One side might kick in pretty well and the other side doesn't, so you always want to train this stuff on both sides. And then I'll talk really quick for about 30 seconds. Then you can progress this with things like your squats, rows, lunges, things like that. Higher progressions are things like, for women who have incontinence, doing like a walking, like a monster walk kind of a thing, where they're exhaling as they come down, and you're starting to simulate more of what happens in single leg stance if they were running and things like that. Jumping jacks, so inhaling as you come out, exhaling, lifting through the pelvic floor as you come together. And we're talking about slow. We're not talking about cranking out your jumping jacks, like inhale, exhale. But you're starting to get some bounce and you're starting to get some movement, and you're seeing in the progression, does that start to make you leak? If it does, it's too much. You need to go back, okay? Erin.
For someone who's not currently having this issue but just looking forward preventatively, how much time?
You're asking for a friend, right?
How much time should we be spending as a preventative measure doing exercises like that on our own? Like in a warm up 5 minutes with
Yeah.
every move?
So that's a great question. Ideally, you want to be incorporating this all day, every day. You have to do it for the 5 minutes here and the 5 minutes there to start training it. But ideally, as you go to pick up your kid or you go to pick up that dog food, you already are so trained that you know you're going to exhale and you know your pelvic floor is going to kick in and your transversus abdominis is going to kick in. But until it gets to that automatic state, we have to practice it. So ideally, all day, every day, you're bending down, you're coming back up, you're going to sit in a chair, you're coming back up. So you don't have to, again, graded contraction to the task at hand. You're not doing like maximal contraction or anything. But you can practice this stuff. And again, I'll say it again, most women have more trouble with the relaxation than the contraction. So if all you do is practice the relaxation on the inhale, you're already starting to train the system, okay? So I think that's it. Thanks, guys.
Thank you.